Welcome to Topic 4, Part 2. In this screencast, we're going to talk about disorders of hemostasis. Here are the learning objectives. So platelets, also called thrombocytes, they play an important role in blood clotting by forming the platelet plug. They only live in the circulation about 8 to 9 days. Many of them are stored in the spleen and can be released when needed. Thrombopoietin is the hormone that stimulates platelet production from the bone marrow. Hemostasis, this is a series of reactions designed to stop bleeding. There are multiple steps, starting with a vascular spasm to minimize blood loss, followed by the formation of the platelet plug, blood coagulation, which involves clotting proteins, clot retraction, and then clot breakdown or fibrinolysis. After we talk about normal hemostasis, we're going to talk about abnormal hemostasis, in which we have either inappropriate clot formation or insufficient clot formation. So let's start with the first step, vasospasm. This is an immediate response as a result of blood vessel damage. So here we have a little damage. The things that trigger this include damage to the smooth muscle of the blood vessel, chemicals released by the endothelial cells and by platelets within the blood, as well as reflexes initiated by pain receptors. And so here these blood vessels constrict, and this can act to minimize blood loss and also minimize a decrease in blood pressure. At this time, the endothelial layer starts becoming sticky, which will aid in the clotting process. The next step is the formation of the platelet plug. So when this endothelium is damaged, the platelets start to swell and form spike processes, and then they stick to the collagen of the injured blood vessels by an intermediate called von Willebrand factor. Once the platelets get activated and aggregate, they release thromboxane A2 as well as ADP, and that's going to cause vasoconstriction of the blood vessel, and it's also going to draw and attract more platelets to the area. So more platelets come to the area, they degranulate, release thromboxane A2 and ADP, and this is going to cause more platelets to come to the area, and so forth, in a positive feedback cycle until the platelet plug is formed. Coagulation is the next step. And this is the process in which the blood gets transformed from a liquid into a solid blood clot or thrombus. So, and this involves clotting proteins that are found inactive in the blood, and then they get activated, and each factor then activates the subsequent factor, until we end up with the final steps in which prothrombin gets converted to thrombin, and then thrombin converts soluble fibrinogen into insoluble fibrin strands. There's a variety of things that are involved in coagulation. So we need these plasma proteins, these factors, these clotting factors. Most of these are synthesized in the liver, and at least 4 of these require vitamin K as a cofactor. So this is important when we talk about coagulation disorders in, say, liver disease. They circulate as inactive factors, and then, as I mentioned, they get activated sequentially by the previous factor. And then we need that von Willebrand factor. That's the factor that is required for platelet adhesion, so formation of the platelet plug. And then calcium is an important cofactor in blood coagulation as well, so appropriate levels of calcium are also necessary. The next step is clot retraction, and then the breakdown of the clot. So actin and myosin in the platelets are going to contract, and this kind of squeezes the serum out of the clot, and it kind of causes it to shrink and pull the ends of the damaged vessel back together. And then clot dissolution, this is the process of breaking down clots. Plasminogen is an inactive enzyme that gets trapped in the clot, and during the formation of thrombin, one of the clotting factors, it actually activates plasminogen activators, and plasminogen activators convert plasminogen into plasmin, and plasmin is the active enzyme that breaks down the clot. Now, recombinant tissue plasmin activators are given to stroke victims or patients, and this is to help break up blood clots. So now let's talk about disorders of hemostasis. There are two ends of the spectrum: hypercoagulability states, in which we have inappropriate clot formation, including venous thromboses, clots within the venous system, arterial clots, clots within the arterial blood vessels, and thromboembolism, a clot that's formed and then breaks loose and travels in the circulation. And then on the other end of the spectrum is bleeding disorders, in which we don't clot appropriately in response to the stimulus and we bleed. Okay, so let's talk about some of the causes of hypercoagulability states. We can have an increase in platelet function, and this can be caused due to an increase in platelet number. And this can be caused by a reactive disorder, such as in reaction to iron deficiency anemia or in reaction to chronic inflammation. It could be caused by a myeloproliferative disorder. This is where there's too much stimulus in the bone marrow, such as with polycythemia vera, which we're going to talk about later. Or we can have an increase in platelet function due to endothelial injury. The endothelium can be damaged with atherosclerosis, can be damaged by high blood lipid and cholesterol levels, and can be damaged by smoking. The next cause is accelerated activity of the clotting system. This could be due to an inherited disorder or primary disorder, in which we have a mutation in clotting factor genes. Or another cause is antiphospholipid syndrome. This is one of your case studies is about antiphospholipid syndrome, so you can read about that. Or it could be acquired or secondary, and this could be due to prolonged bed rest or immobility, in which the clotting factors are allowed to kind of build up. This also can occur with heart failure or myocardial infarction because the heart is not pumping efficiently. It also occurs with malignant diseases, and also with oral contraceptive agents and pregnancy, both of which increase the clotting activity of the vascular system. Next, we have bleeding disorders, and these can be caused by disorders of platelets. For instance, we can have too few platelets, thrombocytopenia, where we have less than 100,000 platelets per microliter of blood. This can be caused by a decreased platelet production due to bone marrow dysfunction or depression. It could also be caused by immune thrombocytopenic purpura, and this is an autoimmune disorder in which we have antiplatelet antibodies. It could be due to consumption of platelets, for instance in DIC, which we're going to talk about at the end of the screencast. It could be due to pooling of platelets in the spleen. It could be due to dilution of platelets, for instance with a massive blood transfusion. And then we have thrombocytopenia. This is when we have impaired function of the platelets. This could be inherited, so we have an inherited defect of platelet adhesion, for instance in von Willebrand's disease. Or we could have acquired defects of platelet adhesion, such as with aspirin. Aspirin irreversibly blocks the synthesis of thromboxane A2 for the life of the platelet. This is used to the advantage in heart patients who might take a baby aspirin a day to block some of that platelet production of thromboxane A2. NSAIDs, they block the cyclooxygenation pathway, but this is just for the duration of the drug rather than for the life of the platelet. Uremia is when we have kidney failure, and this can also impair platelet function and lead to problems with blood clotting. Then we can also have coagulation disorders, so disorders of the clotting factors. These could be hereditary, in which case we call it hemophilia. And with hemophilia, we have a congenital lack of key clotting factors. Most common types are genetic and carried on the X chromosome, so they affect males only, but females can be carriers. But there are other kinds that also can affect females. And then acquired bleeding disorders are acquired later on in life. And this can happen with liver disease, because remember the liver produces most of the clotting factors, or with vitamin K deficiency, because remember vitamin K is necessary for activation of at least 4 of the clotting factors. Okay, so what are some of the manifestations of bleeding disorders? We have easy bruising, bleeding from the gums, epistaxis or nosebleeds, and abnormal menstrual bleeding, melena, which is large volume blood in the stools, petechia. These are these pinpoint flat spots on the skin and mucous membranes. Purpura, these are kind of like larger purple spots of bleeding under the skins. You can have bleeding into the joints. Hemostasis, which is bleeding in the respiratory tract. Okay, the last topic we're going to talk about is disseminated intravascular coagulation, or DIC, sometimes called death is certain. This is a combination of excessive widespread clot formation followed by consumption of clotting factors and then widespread bleeding. And this is secondary either to endothelial injury via the intrinsic pathway or tissue injury, or both. So endothelial injury may occur as a result of trauma, burns, sepsis, hypoxia, acidosis, shock, or vasculitis. The extrinsic pathway involves tissue injury and may occur with trauma, sometimes in obstetric complications, or sometimes as a complication of cancer. In either case, we have excessive injury of either the endothelium or the tissue, and this leads to activation of thrombin. So we get large production of thrombin. Thrombin is going to lead to activation of the clotting cycle and widespread fibrin deposition. So these are going to cause blood clots, and this can lead to tissue ischemia, plus it's going to use up a lot of the red blood cells, and that can lead to anemia, hemolytic anemia. Next, we have platelet consumption, because we're using a lot of the platelets to form the platelet plug, and that can lead to thrombocytopenia, and eventually that can lead to bleeding. And then finally, thrombin, remember, activates plasminogen, and this can lead, or plasminogen activators, and this leads to the generation of plasmin. And remember, plasmin breaks down clots, so it causes fibrinolysis. So then we get massive clot breakdown, and that's going to lead to bleeding. This condition has a very high mortality rate and poor prognosis. Okay, you want to probably pause the video and make sure you can answer the concept check questions, and then we'll take a look at the next set of questions. So what is the effect of von Willebrand disease on the platelets? Okay, give you a minute. All right, and the answer is going to be decreased platelet aggregation. Remember, von Willebrand factor is that intermediate that helps that platelet stick. Next scenario. A man had a stroke and the doctor gave him tissue plasmin activator, or TPA. Why? What's the doctor trying to accomplish? And the next part of the question is, one of the man's relatives wondered why they did not give him heparin or warfarin instead. What is the difference, and why might TPA be more appropriate? Okay, so think about that for a minute. Okay, and the answer is, well, TPA is a clot buster, so they're trying to treat the patient right away by breaking up those clots that are blocking the blood flow to the brain. Heparin and warfarin are anticoagulants, not clot busters. They may be given to prevent further clot formation, but they're not going to break down the clots. Next question. John has liver disease, Jane has a vitamin K deficiency, and Jim has thrombocytopenia. They all have 3 different medical conditions, but they all have the same complication, a problem with hemostasis. So in each case, describe how their medical condition, given above, leads to problems with hemostasis. Okay, so John, he has liver disease, and remember the liver makes most of the clotting factors. Jane has vitamin K deficiency. Remember, vitamin K is necessary for activation of 4 of the clotting factors. And Jim has thrombocytopenia, which means a low platelet count. And so he's going to have trouble clotting because he doesn't have enough platelets. All right, that's it. We'll see you for part 3.